One sector which was a buzz yesterday was the healthcare pack and the hospital pack on the back of the regulation which has been proposed with regard to curbing room rates and capping it to the extent of prices in three-star hotels. We have with us Abhay Soi, who's the chairman and managing director at Max Health, joining us. Abhay, just give us a sense, what does this mean broadly? And how realistic is this? I know it's not generally a comparable versus government hospitals. Of course, it's not. But give us your, initial take of what this means for you.
So I think, the report is on availability of affordable healthcare. And I think there are two things which are required for that. One is you require more healthcare, which is provided by hospitals, and you require them to be affordable. And the question is this, in order to set up new hospitals, you need them to be viable. Otherwise, why should anybody put up any hospitals? Now, hospitals typically operate at about an 8 to 10% profit margin, which is profit after tax. I think the outliers will be about 14, 15%, and generally some of the sort of lowest things would be about 4 to 5%. Now, on a capital-intensive business, if you're not going to be doing a 10% profit after tax, then you're not going to be able to afford setting up hospitals. Now, look, I think who you have to solve for are people who are going to be putting up hospitals today, not people who already put up hospitals, because you need to make it viable for them. Now, in the report, I read that an average billing at a private hospital was about 37,000 rupees, whereas in a government hospital, it was 2,200 rupees. So therefore, it was 15 times a government hospital. But I think it sort of doesn't look at the fact that government hospitals are subsidized. And frankly, I mean, I can't understand how anybody would be able to provide hospital services at 2,200 rupees. And then the question is whether it should be capped at 3-star prices or 4-star prices or 1-star prices. I think that really needs to be determined in terms of what the viability is of any hospital that is going to be set up. So if a new entrepreneur is going to be setting up a hospital in Patna, he's going to see what is the cost of land, what is the cost of construction at that point of time, and is it viable, at least minimum risk-free returns that he's able to generate through that. And I think in Delhi or Bombay or anywhere else would be a similar sort of exercise which will happen. So once you cap these rates, how do you sort of solve for what the construction cost is, what the land cost is, and so on and so forth? And first and foremost, I think what needs to be seen is whether the 10 to 15% profit after tax in a capital-intensive business, now this is not a services business, it's a capital-intensive business, right, is adequate or is it egregious?
Abhay, hi, morning, Sajid here. I think the government is also trying to, give an indication to the industry that, you need to keep a check on the kind of rates that you are asking. It may not come through because it's a parliamentary recommendation, but the health ministry may look at it saying that, maybe you have to keep rates little softer as compared to what we are seeing today. Is that one of the things? And is the industry, as an industry leader, are you also trying to engage with the government on self-regulation rather than they bringing in caps?
So let's look at that, right? Let's look at the rates. Let's assume that you can bring down the rates by 10%. Then you will wipe out the entire 10% net profit margin that you have. So the net profit margin today that you have of 10% is in spite of the rates that you have. So if they were egregious and you want to bring them down, of course you can, right? I mean, eventually it's a parliamentary committee which has wise people, and if the government tomorrow in its wisdom believes so, then if you cap prices, let's say even if you bring it down by 10%, you're going to wipe out the entire profit margin. Who is going to be setting up hospitals after that? I think, that you have to solve for that as well.
And since you said it's a capital intensive business, is the government trying to say that you need to cap your returns at certain level, especially return on equity or return on capital employed?
Fair enough. So what is the return on capital employed for the hospital business as a whole? I think it's in high single digits. If you look at the industry, the listed players out there are 17 listed players. I think the average net profit margin is about 10.6%, and the return on capital is about again, is I think in late single digits, early double digits.
And does and as the
Again,
industry.
again, my point is, who are you trying to solve for? You have to solve for the next person who's going to be setting up a hospital.
So,
And
so
he has to take into account, okay, what that land is going to cost, what that construction cost is going to be at that point of time. Similarly, you're trying to solve for the next patient who's going to come to your hospital. See, look, we can't believe in free markets and not believe in the will of free markets. The question is, does any private player have monopoly? If he has monopoly, he'll be able to tinker around with the prices. The fact is, nobody does. People are still 20 to 30% of business is being conducted at CGHS or government rates, which are less than half of cash rates, right? I mean, the reason you do those is because you've got idle beds. Now, frankly, okay, I mean, if you were to go below that in a free market, and if you had these egregious returns, then you have a lot of players coming in, right? And that's not what the situation is. I mean, you have to define what egregious returns are. Is it a 30% profit margin? Is it a dividend paying sector? What is happening to the cash which is generated? Is it an egregious amount of dividends or egregious amount of this thing? It's not even a dividend paying sector for that matter.
So, are you going to see, maybe future capex going on a slow roll here, given the fact this now becomes one of the talking points for anyone who's trying to invest in healthcare in India, especially secondary and tertiary healthcare?
Well, some things, if we are going to make, there are statements over there that FDI should be capped, okay, in healthcare sector. Then I think those are causes of concern for a foreign investor today, especially in a sector where you require more and more capital coming in. Because look, without that, I don't think we'll be able to provide healthcare to the ensuing generation. Do keep two things in mind. A large part of the population, particularly the middle class, lower middle class, used to visit nursing homes and government hospitals. I think all of us were born in government hospitals or nursing homes. But today, a very, very few percentage do that. So there's been a shift. Secondly, our average age of the population demographic is 29. But 15 years later, let's make no mistake, we'll be closer to the European age. The baby boomer population in India is going to age. And we need to create assets. We need to create those beds. There are less than 100,000 beds in the private sector as far as tertiary care is concerned. I mean, UK has less than 5% of our population, okay, and has 200,000 beds. So effectively, I mean, I think if we're not going to have support in the sector, if we don't have FDI, if we don't have other players coming in and so on and so forth, I think we're going to fail the future generations.
Abhay, does this in any way change the stance that you have in terms of capex? Would you at all pause it? Would you wait and watch? How would you deal with this?
Not at all. I think, this is a report. This is the 176th report of the Parliamentary Committee on, one has to see what the government believes in its wisdom.
And Abhay, last off, there is a capability in the market to absorb the kind of rates that private hospitals are charging, right? I mean, and hence business is doing well for you all. Hence, there is stronger growth. Is that something that you all have been actively informing the government as well, that there is an active market?
So look, you can perform the same procedure through a general surgery, for example. You can perform the same procedure through laparoscopic. And you can perform the same procedure through robotic. And tomorrow it will be, let's say, other innovations which will come, novel therapies and so on. General surgeries are typically cheaper than laparoscopic, are cheaper than... now, we can take away the choice and say, look, let's make healthcare cheaper. Let's remove robotics. Let's remove laparoscopic and we'll do general surgeries. Let's make it all even cheaper. Okay, why should private hospitals have air conditioning in it? Because, government hospitals don't have. So we can make it even cheaper. Why should it have a particular kind of F&B, particular kind of quality standards and so on and so forth? The point is this, do you want to take that choice away?
In that sense,
I mean, we have midday meals in India. You have PMJY rates and you have PMJY hospitals and you have hospitals which are providing novel therapies. But, for people who can afford it, should you take the choice away? That's a question that you have to sort of answer, right?
Need for this is to have a better health insurance system in the country, so that healthcare can, the standard of healthcare is also risen, as well as cost of healthcare is managed properly.
Look, by the end of the day, insurance is again a pass-through, right? The cost of healthcare is what the cost of healthcare is. I mean, today, India is the cheapest producer of healthcare in the world. When we look at global medical tourism, it's not people from Qatar and Saudi, etc., come to India. It's people from Sudan, it's people from Ethiopia, it's people from the SAARC countries, from Myanmar, from Bangladesh. These are the poorest people in the world. They're coming to India because it's the most affordable healthcare. It's the cheapest healthcare in the world, right?
Abhay, I take all your points, but I'm just trying to get to the moot point, which is that the capping of the room rate is to the extent of a three-star hotel, which is certainly not cheap in similar area. Do you believe that that too is a little bit of an overstretch?
I want to give you two facts.
Please.
I want to give you two facts.
Please.
Okay, and just keep this in mind, right?
Yes.
First and foremost, a very important indicator for a hospital is ALOS, which is average length of stay. The shorter the average length of stay, the better it is for any hospital. The longer it is, that means the hospital is doing poorly. Why? Because for every day that a patient stays in hospital, a hospital loses money. You make money in a daycare, you make money in a procedure, you lose money every subsequent day. Now let's come to the three-star hotel. A three-star hotel does not have resident doctors or doctors attached to it or nurses 24/7. We have 5 nurses attached to rooms. There's a particular ratio with NABH that requires you to sort of follow. Okay, a three-star hotel does not have medical lines going through it. The capital cost is different. The operating cost is different. And all in, okay, whether it costs 3-star today, 4-star, 5-star, 1-star, the point is this, all of it drills down, okay, to the 10% margin. Let's say somebody's operating at a 5-star hotel rates. You want to bring it down to 3-star rates? Let's bring it down to 3-star rates. Impact is what? Impact is your profit after tax comes down. First and foremost, is that 10% egregious or not? If it is not egregious, okay, then, what are we doing?
Have you done an analysis of what is the kind of capital cost for setting up one hospital room, and the recovery, and how much time does it take for a hospital to break even that room?
Look, okay, let me put it this way. Now, let's say you set up a hospital, which you have oncology, you have cancer over there. Okay, somebody decides to put a proton beam. Because proton, okay, again, for very novel cases, for very sort of specific cases, may be necessary. But the cost of that machine, okay, is about, when you set it up, it's about 150 crores. That one machine alone. Now, you can decide not to have it and not to provide the choice. Another hospital has a particular LINAC machine which can cost about 30 crores, and you can decide not to have that machine. Now, essentially what you're doing is, you could be a 100-bedded hospital and you're defraying that cost into so many beds or whatever. But eventually, that's how you're charging, right? Your average, cost in a hospital includes all of these. So it's like saying a hotel, okay, has banquet and has rooms. What you're doing is you're taking earnings from your banquet and you're distributing it in the rooms. If I have a bigger banquet, okay, I have more earnings from that. But I have a more cost as well.
Point taken. Point taken, Abhay.
I mean,
Thank you so much.
It's not the same. And
Right.
I've heard this thing about standardized costing. Okay, we all have parents. When our parents go to a hospital for the same problem, for the same disease, some doctor will give you a particular antibiotic and another parent B antibiotic. It depends on what their comorbidities are, what their other. Somebody will be given a medical treatment, somebody else may be given a clinical treatment. How do you standardize it? Are human beings standard?
No, absolutely. Abhay, you've been extremely candid, and a lot of the arguments you make, make a lot of sense. Thank you so much, though, for coming in and giving us your perspective. Really appreciate it.
Thank you.